Good evening, and thank you for joining us for this roundtable discussion regarding aspirin and your heart. My name is Dr. Lawrence Solomon. I'm one of the cardiologists at the Heart and Vascular Institute at Nuvance Health, and I'm joined by my colleagues, Dr. Mark Harrison and Dr. Benjamin Schaefer and Dr. Ira Galen. And this is a particularly timely subject, I think, for two reasons. One, we're just approaching February, which is Heart Awareness Month. That's a time where each year we put particular emphasis in the cardiology community in terms of preventing heart disease. And the second reason is that aspirin has been in the news quite a bit lately because the U.S. Preventive Services Task Force recently updated their guidelines about how and when aspirin should be used in terms of preventing heart disease. So first, just a little bit of background. Aspirin obviously is not something new. It's been around for a long time. And in fact, in its natural form, salicylic acid, it's been used since ancient times. It was in the late 1800s that aspirin was first proven to be beneficial with respect to its anti-inflammatory properties in treating acute rheumatism. And then it was in the 1950s where it was first studied formally and published regarding the specific benefits of aspirin in terms of preventing heart attack and stroke. So this is something that's been used for a long time with the goal of preventing heart disease. And the question is, what's changed recently? Why are we talking about this? Why is this in the news? And as I alluded to, the U.S. Preventive Services Task Force, that's an independent organization that does make recommendations regarding screening issues and other medical issues. And in this latest update that was, the draft was released in October of 2021, the task force suggested that perhaps we shouldn't be using aspirin as much as we are. So with that in the background, I thought that we would take the next 15 minutes or so to try to unwrap this a little bit more, understand why the confusion, why the revision of those guidelines, and to bring this back to you, the patient, because this is not always such an easy question to answer, and not all patients are the same. And although we'll cover some of the basic concepts here, obviously this is a very important decision about whether or not someone should be on aspirin or not, and it's something that certainly we would encourage you to speak to your individual physician about. So with that, I think I'll turn to Dr. Galen to start here, and specifically I'm going to ask Dr. Galen to comment on when we talk about prevention, there's, as I said, of course, different patients. There are those patients who have never had a cardiac event and we're trying to prevent a first event. And then there are those patients that have demonstrated heart disease. They've already had an event and we're looking to prevent a recurrent event. So Dr. Galen, if you can kind of help us to understand what's the difference between primary and secondary prevention. And then could you take a moment to focus a little bit on secondary prevention? What's the role for aspirin there?
Absolutely. Thank you for the opportunity to talk and be part of this roundtable discussion. And as you mentioned, it's really important to tease out the difference between primary and secondary prevention. And along those lines, it's really important to understand that the benefit of taking aspirin is not the same for everyone. And when we recommend that someone take an aspirin, we're going through that exercise that you just described, and we're putting people into two different categories. Those who have never had a cardiac event, heart attack, or stroke before, or those who have. And when we recommend aspirin to prevent the first event, that is, as you said, primary prevention. The use of aspirin, though, to lower the risk of a second or third event is called secondary prevention. And these two strategies are different. because anybody who has had a heart attack or stroke is at a much higher risk of another event than anyone who has never had an event to begin with. And before we focus on this idea of aspirin for primary prevention, really what has come out in the guidelines and a little controversial, I'm just going to take a moment to give some background and reference of the use of aspirin for secondary prevention. As you mentioned, aspirin has been around for a long time. And the use of aspirin to treat patients with a prior heart attack or stroke has been our standard of care for over 40 years. In fact, in 2002, all of the data on aspirin for secondary prevention was analyzed. And the results showed that in tens of thousands of patients with a prior heart attack or stroke, that aspirin resulted in a significant reduction in a recurrent cardiac event in both men and women. And it also showed that low dose aspirin was found to be just as effective as high dose, but a lower risk of bleeding. So aspirin as a secondary prevention therapy to lower the risk of a serious cardiac event is well accepted and recommended by several major medical societies. So before I turn it back over, let me just, bottom line. If a patient has had a heart attack, a stroke, a cardiac stent, a history of coronary artery bypass surgery, that patient should keep taking aspirin, or at a minimum, do not stop taking aspirin until you have a discussion with your treating physician. The new studies that we'll be discussing, the guidelines that have changed, these do not affect the importance of this treatment of aspirin in this specific group of secondary prevention patients.
Great, thank you. One of the questions that I get asked frequently is, well, I haven't had a heart attack, but I've been told that I have a blockage in one of my arteries. So what do you say to that kind of patient, Dr. Galen? Is that primary prevention? Is that secondary prevention? Is there one answer that fits all for those types of patients?
Yeah, interestingly, I would say that those probably are the most common patient that we see in the office and have this conversation with. Personally, I group those patients into a subclinical atherosclerotic group. They have never been documented to have a heart attack or stroke, but also they have some documentation that they do have a blockage in a major vascular bed. My personal opinion is those patients should not be considered as a primary prevention patient, that they really are and have been demonstrated in the medical literature to be at a higher risk of having that first event. In those patients, I think it comes down to an individual discussion with the treating physician where it needs to be tailored. Is aspirin right for that specific patient?
Right, and I would agree with that. I think a true primary prevention patient is someone in whom we really don't have any evidence that they have atherosclerotic disease. And although someone may not have had an event, if they've got a significant burden of atherosclerosis, cholesterol plaque in the arteries, clearly that's not the same as someone that's had no disease. Well, let me switch gears now. You've focused on the secondary prevention group, and now let's come back to primary prevention. So these are patients that don't have any documented disease. They've never had a cardiac event specifically. And I'm going to turn to Dr. Harrison to comment on those patients. And specifically, this is what the recent update from the U.S. Preventive Services Task Force was focused on, those patients in this primary prevention category. So tell us a bit more, Dr. Harrison, about that group and what's changed. Why have these guidelines recently been updated from 2016 to 2021? What's different?
Great, thanks, Dr. Solomon, and thank you all for tuning in and allowing me to join in this roundtable. Again, I think the key thing that all of us who practice cardiology and see patients every day who are focusing on those in the primary prevention space, and to reiterate, those are patients in whom we are trying to prevent heart attacks, strokes, other atherosclerotic events, have not developed those problems yet. There are many strategies that we're all familiar with, aware of, and comfortable with in trying to reduce that from happening. Things like achieving good blood pressure control, optimizing patients' nutrition and contributing to weight loss, diabetes control, cholesterol lowering. Those are all things that we strive for, and we work with our primary care physicians as well to help those patients in that space. As part of this, over the last many decades, the introduction of the idea will having patients take aspirin in some form or another. It used to be even higher dose than it is now, but the common question that we're being asked is, should we have patients take 81 milligrams of aspirin every single day to reduce their risk of heart attacks and strokes? The problem with aspirin, though, while it is a mild blood thinner, which helps prevent blood clots, the flip side of that coin is because it is a blood thinner, it can contribute to a higher risk of bleeding. And that trade-off is something that has been studied over and over and over again. What has changed, and what you alluded to, is there have been 3 important studies over the last few years, which has changed the USPSTF's thinking, the Preventative Task Force guidelines. One trial, the cardiology community likes to use big acronyms to title their trials. One trial was called ARRIVE, Aspirin to Reduce the Risk of an Initial, again, the important thing is an initial vascular event. And they enrolled tens of thousands of patients, which is a big trial, over the age of 55. They gave half those patients aspirin and half did not give aspirin. And importantly, there was no difference in heart attack rates, and there was a higher risk of bleeding in those who took aspirin. So that is strike one against recommending giving patients aspirin. The second trial was called Ascend, a study of cardiovascular events in diabetics. There was a very slight reduction in heart attacks for those who took aspirin, but again, almost predictably, there was a higher rate of bleeding. And this was a trial that enrolled diabetics over the age of 40, and diabetics are at higher risk of cardiovascular events. The final trial, called Aspirin, was aspirin in reducing events in the elderly. That enrolled patients over the age of 70, and it showed no benefit in reducing heart attacks and strokes in those who were given aspirin therapy as a form of primary prevention. So in its totality, these 3 large, well-designed, well-executed trial on balance did not show a major benefit for patients taking aspirin 81 milligrams once a day routinely. So the USPSTF completely changed their guidelines. They say do not recommend aspirin at all in patients over the age of 60 for primary prevention, and in patients between the ages of 40 to 59, depending on their risk, given other risk factors like blood pressure, diabetes, etc., it is an individualized discussion that the patient should have with their provider. So because of these 3 major trials, large trials overall, which did not show that aspirin provided a meaningful benefit and did expose those patients to higher risk of bleeding, the recommendation was changed.
Thank you for clarifying that. And again, just to be clear, this does not mean that anyone over 60 should not be on an aspirin. We want to be very clear about it. There are some patients who have not had a heart attack where it may be felt that the benefits outweigh the risks based on their individual circumstances. If they've got a known blockage in one of their arteries, even though they may not have had an event, that's someone where the benefit of aspirin is significantly greater. So, and again, this is in distinction from what Dr. Galen was talking about, the secondary prevention category, where it's clear there's 20-25% risk reduction in those patients, but in the primary prevention group that Dr. Harrison just described, it's not as clear cut, particularly in the older patients, where we see in these recent studies, particularly the Aspirin trial, where there was no clear benefit, and in fact there was a trend toward harm because of that bleeding risk. I'd like to turn to Dr. Schaefer now to shed a little bit more light about that bleeding side of the equation here. What do we mean when we're talking about bleeding risk? And what about the dosing of aspirin? Does that make a difference in terms of one's risk of bleeding?
Yeah, thank you. Thank you for giving me the opportunity to speak in this roundtable, and welcome, and thanks for tuning in. Yeah, aspirin is actually a very interesting drug if you look at the history of it and if you look at how it works. What is amazing is that very, very low dose of aspirin are needed, to infer that inhibiting effect, that your platelets don't get sticky and you don't have a heart attack. But the same effects, unfortunately, also increase the bleeding risk. You're basically trying to achieve the same thing. And while in the old days, when your mom may have told you, okay, just take an aspirin or take a gram of aspirin for your pain, these very, very high doses we used had a lot of GI side effects. For the longest time, we felt we could get away with giving a mini dose of aspirin to almost everybody. And that may have been partly driven by the fact that, even 20, 30 years ago when that sort of came about, we didn't have a much to treat heart disease. We weren't very good at it yet. And we have so many more modalities now that we do reduce the overall risk of heart disease that we, I think, dilute the effect of aspirin. And aspirin always caused bleeding. I think the last couple of studies we've seen that were referenced, have really brought that to light. For example, in the Aspirin trial, we had, you could get away with taking aspirin every day. We have so many patients say, I took an aspirin for years. Why do I need to stop now? Well, if you're a healthy 70-year-old, your risk may be very small. But the same thing that sort of goes for heart disease, that it increases with age, smoking, high blood pressure, the same factors also increase the risk of bleeding. So basically, now we have an 80-year-old that may not be that healthy, that may have a 5% chance of bleeding any given year. And what we've also shown that these bleeds can be fatal. Now, what's interesting is that we group aspirin among those non-inflammatory, non-steroidal anti-inflammatory drugs, the NSAIDs, that people may know that expression. Now, they all kind of work in very similar ways. Aspirin, however, is the only one that we use in prevention of heart disease, and that has something to do with how it works on the blood platelets. Now, when we take these drugs, they all increase the risk of bleeding. We have to be aware that this is in part dose related, and that we used to give everybody 325 milligrams of aspirin. That was clearly too high. I think what we have to realize is that in people who need aspirin for their heart disease, we should be very careful in taking any of these other drugs. I think that's often not emphasized enough. It can be that you have, a bad headache and you take some ibuprofen. I tell my patients, listen, you have a bad headache one day, take some ibuprofen. It's probably not going to hurt you. It's more the people that have chronic pain that take that on an everyday basis for weeks, months, years, that get into trouble. And it probably will inhibit the good effects of aspirin for your heart. When we talk about those other drugs, I'm often asked what is safe. You should consider Tylenol to be safe. It works slightly differently. Anything else, you really want to have a detailed discussion with your doctor to make sure that you're taking the right drug and the right doses.
Great. Well, thank you for clarifying. Any other tips for patients that are taking aspirin? For instance, taking it on an empty stomach versus taking it with food, taking a coated aspirin versus non-coated. Any other comments about that, Dr. Schaefer?
I mean, I think in part you have to separate the aspirin and somewhat similar drugs out, because they actually can be toxic to the stomach. The way they work on your blood platelets to prevent them from sticking is actually very different from some of the side effects they have on the stomach. And what you have to realize is that, that the stomach probably, while very acidic, still is affected by aspirin directly. The way it works for the blood platelets is really within the liver where things happen, the effect on the blood platelets. So I tell my patients, listen, if you want to take a coated aspirin, it's probably okay. It may be a little better for your stomach, It will reduce the dose of aspirin a little bit because with that coating process, I think comes some problem with absorption. But again, we only need very, very little aspirin to do that. I think once you go into the higher doses, I'm not sure that you're really doing yourself any favor by taking a coated aspirin. If you take 325, 650 milligrams of aspirin, but it may be important for the small doses if you're really sensitive. I personally don't necessarily have recommendations whether you should take it on an empty stomach. I would advise against it unless you have specific reasons. But most people probably be better to take it with food.
Great. Well, thank you. And I want to thank everyone for joining this evening. I think we'll wrap things up here. And I think, you know, as we've tried to convey to you, this is not necessarily such a clear-cut, easy decision whether or not to be on aspirin, whether or not to stop taking a daily aspirin. And this is something that's very much an individualized decision. We would encourage you to speak to your doctor about it. Please don't make these decisions on your own. They're difficult decisions. And again, as we've tried to convey, we have to, when we approach any individual patient with this question, we have to ask ourselves, what's the potential benefit? And making that estimation really has to do with the details of one's medical history and risk factors for developing events. And we have to balance that against what the potential risk for bleeding is. And again, whether someone's already had bleeding problems, what age they are, what kinds of activities they engage in. These are all factors that should be considered when making this decision. So again, I want to thank everyone for joining us. From all of us at Nuvance Health, we want to wish you all a healthy and a happy new year. And we'll close out now. Thank you again.